Hello, everyone. Thanks for joining us tonight. Thank you, Susan. And we're happy to be bringing together themes from two books. One being Frankenstein for the 200th anniversary that Indiana Humanities and Indianapolis Public Library is doing, but also gearing up for Rebecca Splu coming in with some of the Lax descendants, Henrietta Lax. And have many people read the book, Immortal Life of Henrietta Lax? Great.
So good.
People shaking their heads, so that's great, because anyone who's read it, I think, understands the significance of it and appreciates it. So, at Side Effects Public Media, we are the public health desk at WFYI, and we do reporting and community engagement around public health, and we look at the place, policy, and economics and its consequences on our community's health. So that's why this was really interesting for us and why we wanted to do a discussion around it. And though the books are very different, they mirror each other thematically in many ways. They both highlight the urge to learn, experiment, and create, both scientifically and medically. Both of them touch on the unethical collection of body parts as well. And they both have successful creation inside of them. Of course, Dr. Frankenstein successfully creating a monster, which ultimately became destructive, while a surgeon at Johns Hopkins took samples of Henrietta Lax cells, which became prolific beyond imagination. So the parallel that we're drawing here is that sometimes monstrous links research scientists will go to advance itself. In Henrietta's instance, culturing cells against her family's wishes or without their knowledge. And I found a couple quotes from the book that I wanted to share before we start the discussion to just kind of highlight the importance of her legacy on medical science. Before she died, a surgeon took samples of her tumor and put them in a petri dish. Scientists had been trying to keep human cells alive in cultures for decades, but they eventually died. Henrietta's were different. They produced an entire generation every 24 hours, and they never stopped. They became the first immortal human cells ever grown in a laboratory. One scientist estimates that if you could pile all HeLa cells ever grown on a scale, they'd weigh more than 50 million metric tons, an inconceivable number, given that individual cells weigh almost nothing. Another scientist calculated that if you could lay all HeLa cells ever grown end to end, they'd wrap around the Earth at least 3 times, spanning more than 350 million feet. In her prime, Henrietta herself stood a bit over 5 feet tall. And if you've read the books, you know that in 1951, Henrietta Lax was diagnosed and ultimately died of cervical cancer. Her cells contributed to the creation of both prevention and treatments of that disease, the same one that led to her death. And if we look at how Indiana is doing when it comes to cervical cancer, we are greatly underutilizing a cancer prevention breakthrough. Which leads us to our discussion tonight concerning public health and policy initiative in Indiana that wouldn't exist without HeLa cells. So I want to introduce the panelists to you tonight. Elected to Indiana General Assembly in 2012, Representative Sharon Nagel has been a champion of cervical cancer prevention in her role as state representative. In 2017, Representative Nagel authored House Enrolled Act 1278, which requires the Indiana State Department of Health to develop a strategic plan to identify and significantly reduce morbidity and mortality from cervical cancer. Representative Nagel works closely with the American Cancer Society in order to advocate for the importance of the HPV vaccine and is keen on raising public awareness for the existence of cancers stemming from HPV. In addition, Representative Nagel serves as the Vice Chair of the House Committee on Courts and Criminal Code, as well as on the House Ways and Means Committee. Representative Nagel has considerable private and public sector experience, working 14 years in corporate finance for energy and telecommunication companies, 22 years as a small business owner of Wolf's Homemade Candies, 3 years as a grant writer administrator, and 9 years as a clerk treasurer for the city of Attica. Welcome, Representative Nagel.
Thank you.
And I'm not going in order, so sorry for skipping around, but Tamika is a cancer survivor and women's health advocate, and she is the chief visionary at Survivor with a CER, a nonprofit dedicated to cervical cancer advocacy and support. Named a Cancer Rebel by Newsweek in 2017 cover story, Tamika is a highly sought-after speaker on cervical cancer advocacy, cancer prevention, HPV education, and living life with purpose after cancer. She is the author of Seriously, What Are You Waiting For? 13 Actions to Ignite Your Life and Achieve the Ultimate Comeback. Tamika currently serves as the steering committee on the steering committee of the National HPV Vaccination Roundtable. She is a former board member of the Ulman Cancer Foundation for Young Adults and shared her story and experience on presidential cancer panels convened by the White House. An award-winning television producer, Tamika is currently filming a documentary about cervical cancer, the woman living with it, and the vaccine to prevent it. Her story of patient to advocate, survivor to survivor, inspires and mentors not only patients and medical communities, but anyone who has struggled with obstacles in their life. You can learn more at TamikaFelder.com or survivor.org. And Dr. Greg Simmons is a professor of pediatrics and clinical psychology in the section of adolescent medicine, Department of Pediatrics at Indiana University School of Medicine, and is co-director at the Indiana University, Purdue University, Indianapolis Center for HPV Research. He served as the president for the Society for Adolescent Health and Medicine from 2016 to 2017. Dr. Zimmett started investigating attitudes about vaccines for adolescents in the mid-1990s. Much of his research over the past 15 plus years has focused on knowledge, attitudes, and decision-making about HPV vaccination. And as an Indiana native, State Representative Robin Shackleford has dedicated her life to the principles of servant leadership. First elected to the Indiana House of Representatives in 2012, Robin represents House District 98, and she serves as the ranking minority member on the House Public Health Committee. With a career rooted in government affairs, Robin has worked for the Indiana Healthcare Association, Crow Horvath, and Indiana Department of Commerce, the clerk of the Supreme Court and Appellate Courts, and served as a Diversity Affairs Director in the Office of Indianapolis with Mayor Bart Peterson. She is a graduate of Indiana University and IUPUI, having both earned her bachelor and master's degrees in public affairs. With her dedication to community growth and education, Robin served as a president for a number of community organizations and currently serves on the board of Martin University and the Pathway Resource Center. Robin's other civic involvement includes Eastern Star Church Servants in Action Ministry, National Black Caucus of State Legislators, and NAACP. So thank you all for joining us. We'll get started with the questions now. And the first one I wanted to throughout the panel is weaving together the themes of the books, Henrietta Lacks and also Frankenstein, what comes to mind, especially when we think of Henrietta Lacks and her legacy. What does Henrietta Lacks mean to you either professionally or personally? I'll throw it off to, do you want to answer first?
Sure, I could start. So, I think about her story as having, in some ways, there's kind of two different threads, and one has to do with ethics and research, and the fact that her cells were used and cultured without her knowledge and consent is something, so, that there's a fairly long and sordid history of public health research that has been ethically challenged, but I think the positive side is that lessons that we've learned from, for instance, Henrietta Lacks and from the Tuskegee syphilis study and other studies like that really have changed the landscape of ethics in research and the kind of expectations and requirements, that researchers of all sorts, like myself as a behavioral science researcher, all the way to, people who do basic science research. I think the good news is there's a learning from our mistakes, not that there isn't more learning to come to, but I think that's one of the lessons of Henrietta Lacks's experience. And the other is how remarkable her cells turned out to be. I mean, they had been taking cells from people for, as you said, decades without any success. And, her misfortune, which was to have this extraordinarily aggressive cancer, led to the fact that her cells became immortalized. And the kind of phenomenal research that this led to has improved the lives of really millions and millions of people through the kinds of treatments and prevention strategies like vaccination that we have now.
Tamika, do you feel any connection to Henrietta Lacks and her legacy as a cervical cancer survivor?
I definitely feel a connection to Henrietta Lacks on multiple levels, not just as a cervical cancer survivor. There's this, us both being Black women who grew up in the South, who moved to the DC metro area, her living in Baltimore, myself living about 45 minutes from Baltimore. I was treated at Johns Hopkins Hospital just like she was. So I have this connection to her through that shared story of those things. I'm torn as someone who understands, again, being a Black woman, growing up in the South, having parents and aunts and uncles, grandparents who were skeptical of being, used by medical societies for research and different things like that. And I think, and I should also note that I know her, I've met her family members, and I've heard their story intimately, and I know their struggles of really, just like in the movie, of how they felt of what happened to her, and they, share what they feel about her and how they love her, and it's a beautiful thing. So I have that part of it that has evolved since my cancer diagnosis. But there's a part of me that is, I hate what happened to her. But there's this other side that we wouldn't have all of this medical advancement without her. And I think one of the things that has to happen, and in some ways it started to, I'd like to see more of it, that her family, gets what she should have gotten for her part in the medical advancement, but also celebrating her. And I love that this event is happening because she should be celebrated, because there are millions, if not more, of people who health-wise would not be here without her and her cells.
And I'm kind of on the same lines as Tamika. My family has been gravely affected by cancer, all different types of cancer, from lung cancer to renal cell cancer. So Henrietta Lacks, to me, is a medical hero, especially in the African American community. So I look at the positive side of it and what she means to, and what has happened, and the outcomes that has happened because of what was used of her cells. And I hope and encourage even more African Americans to participate in research when it comes to cancer research and other research. I know a lot of African Americans don't participate in medical research, but because there are so many African Americans with medical illnesses and chronic illnesses, especially when it comes to cancer. So when I saw the movie, when I heard her story and listening to her story, it just resonates, especially in our families and in African American families. So yeah, it's just the closeness when you just think about what happened to her and then the positive that came out of her story.
I guess I'll just add, it's really hard to add to this because I would agree with everything that was said here, but it's that double-edged sword. It's so beautiful what has resulted, but I would hope that the ethics have made a tremendous change now, and when it comes to the allowance of someone taking your cells, and we know that in all of our walks of lives, and even in the positions we're in, how incredibly important it is to take that ethical approach. So I think we have to celebrate her in many ways, and that's really maybe the best thing we can do at this point is to focus on.
And my next question kind of goes on to that. Representative Shackleford, as a public health committee member, how do you see policy drive issues that we're talking about, or public health efforts that are happening in Indiana now and in the past, and what might be looked at in the future?
So I looked at some of the legislation that has taken place around cervical cancer, around other states and here in Indiana. In other states, right now currently there's only 3 states that actually mandate vaccinations. That is Rhode Island, Washington, D.C., and Virginia. It is a hard road to try to get a state to mandate vaccinations. We have had legislators even try in our state to try to have a mandate for the HPV vaccination. We have had legislation where we're trying to get more information out there, trying to get that information to boys. Right now, we get that information out to the girls in school. So our legislation right now, when it comes to cervical cancer or HPV, is mainly around allowing pharmacists that now they can give the HPV vaccination, and then we can give that information out to girls. And then we had Representative Nagel's, the strategic plan. So that's where we are as far as our pieces that have passed. When I talked to the Department of Health today to ask them where they are as far as the stages of their strategic plan, they said they're in their initial phase. They're wrapping up the draft. I don't know if you got a status from them. So
We're really close.
yeah, so they said they're close. They're wrapping up their rough draft for the strategic plan, and it should be done by December. But as far as other states, everybody's kind of on the same mode. They've kind of doing the same legislation, either allowing the pharmacists to list it now to give the HPV vaccination, trying to get more awareness out there in schools with kids. So 42 states have introduced some type of legislation when it comes to cervical cancer, and you have 25 states that have usually introduced some type of legislation dealing with kids, either trying to increase the awareness or trying to do some type of mandate to the kids while they're in school. And it's interesting because when I looked at the research, usually mandates have to go through the legislature, but there were actually states that did it like through their state agency where it didn't require it to go through the legislature. And that was actually Rhode Island because their Department of Health didn't require legislative action. And then Texas, their governor actually tried to do the same thing, but their legislature came back and knocked it down. And then the governor didn't veto it. So it's very interesting in trying to get legislation passed when it comes to how do we get awareness out there, how do we look at treatments, looking at mandates. It's very complicated, but all the states are trying to do something.
So I'll ask my question to you. If you wanted to tell us about House Enrolled Act 1278 and why you decided to author that.
Sure. So Representative Shackleford and I were both elected the same year, and boy, did we learn a lot about all the roadblocks you could encounter. And one of the roadblocks, of course, had to do with cervical cancer, and watching for 2 sessions, the legislation just not receive any hearings, a lot of pushback. And I remember having many conversations with my fellow representatives saying, I just don't even understand why this is an issue. So it seemed just so logical that this should be a no-brainer. But it wasn't, and there were many obstacles. And what we discovered is we were going to have to regroup and think about how we could go about approaching this so that we could pass some legislation that could move us in the right direction. Was this the perfect piece of legislation? Of course not. You can always improve. But the approach we decided to take after 2 failures, and I was always just supportive of those other pieces of legislation. I wasn't the author. So I have to say that this was very much a team effort. I just got to carry the ball over the line. There were many legislators involved in supporting this effort. But what we were able to do is kind of step back and think about, what were our roadblocks? Well, we know that if there was any hint of the word mandate, the bill was going to be dead. So we had to make sure that there was some language in there that specifically stated that the strategic plan would not include a mandate. We also took a 3-prong approach. We took it as, this is education, this is prevention, and this is screening. So there were 3 angles we wanted to really research and figure out how we can tackle this issue in the state of Indiana. The state health department, of course, was very supportive. That was critical. And we also had an executive branch change, so that also removed one of the roadblocks. And then it was just having more and more conversation about this issue being an issue and why it's so important for the state of Indiana. And I can tell you that we went from legislation that couldn't get a hearing to legislation that passed by 100%. I mean, it just seemed, how did that happen? But it did. It did. So we finally figured out exactly how to craft it so that it was palatable for those who were struggling with it. We also removed the word HPV from the legislation. It just referenced cervical cancer. Of course, underlying, we all know what causes it. So it was kind of an interesting tactic, but it worked. So now we are in the forefront. We're waiting for this strategic plan to come out. And I'm really excited about receiving this strategic plan, because I think what it's going to help do is really identify what are the areas of barrier and what do we need to do policy-wise or legislative-wise. And it may not be a legislative action. It may be just a different approach in the medical community. So this piece of strategic plan, I believe, really will create the next roadmap to where we need to go in the state of Indiana, because we are failing right now.
Did you do all that in one session?
Well, again, there was a lot of work prior to me. So we did it, yes, in one session, that piece of legislation, but there was previous legislation that taught us a lot that didn't get the legs, so that we were all communicating about. So, and sometimes, maybe it's just maybe some of the previous legislators took a harsher approach on it, and maybe I learned a little bit from their approach. And then we also learned, what were those trigger marks that, they didn't have the benefit of knowing that was going to be, an anti-trigger mechanism, so to speak. And I was able to head that off on this piece of legislation. So I learned a lot from the previous failures.
I also love when you guys did your legislative work here, that you included the patient voice. I think when it comes to cervical cancers and other HPV-related cancers, a lot of times parents or people in the community, the general public, they don't think that this is something that they can have happen to them or their children because of stigma. And so they think that there's only a certain type of woman that cervical cancer would happen to, and it wouldn't happen, to my precious child. And I think that that's been a big roadblock for cervical cancer and HPV education when it comes to vaccinations, because people don't see it as an issue that would affect them because of the shame of HPV. A lot of women don't speak out about this particular cancer. And I think that it is incredible that you made sure that when you were talking and putting these out there, that you use the patient voice, because it's a powerful voice. We see it in other cancers, but in this particular cancer, those voices are sometimes limited because of shame and stigma. So thank you both.
And it is interesting that it's such a policy issue right now as opposed to just a public health issue. So I was wondering if, Dr. Simmons, if you could tell us about your research related to vaccinations, the patient populations, provider populations.
Sure, yes. So I've been actually studying attitudes about HPV vaccine since before it was licensed, starting in the late 1990s. And one of the things we were talking about before this got started was how some of my initial research and other people's research at the same time indicated widespread acceptance of HPV vaccine. I would say about 80% of parents that I surveyed said that they would vaccinate their kids. And then something happened, right? So the vaccine got licensed, and it turned out I had more work to do, because almost immediately there was controversy that was generated in part by Governor Rick Perry and some of the other states that very quickly and without a lot of thought seemed to have school entry requirement legislation being considered. And it turned out that Merck was behind some of the lobbying with this, and that ended up really blowing back, I think, and setting us back with HPV vaccine. It raised people's suspicions that this was sort of a conspiracy between pharma and government, and it really set us back in a big way. So my anticipation that there'd be widespread acceptance didn't prove to be true. I think HPV vaccine also became something of a target for a lot of anti-vaccination advocacy or work, that it seemed like a prime vaccine to attack, in part because it was associated with a sexually transmitted infection. So I've had a lot of work to do. I haven't run out of research to do around HPV vaccine. I wish I had. I'm continuing to do research. Some of the studies focus on healthcare providers and how they can do a better job of recommending the vaccine. It's widely accepted throughout, pediatrics and family medicine that one of the big roadblocks is that healthcare providers are not making a good, strong recommendation at the recommended age of 11 to 12. I mean, all 11 and 12-year-olds should be receiving this vaccine. And part of that is for pediatricians, family practice physicians, nurse practitioners, pharmacists, anyone who has contact with that child, making a strong, clear, simple recommendation, bundling the vaccines. There are 2 other vaccines that are required at that age, that are required actually in Indiana for school entry: Tdap, tetanus, diphtheria, and pertussis, and meningococcal ACWY vaccine. And that's a time when HPV vaccine should be delivered as well. So some of the research that we've done, my colleagues and I, include listening and analyzing audio tapes of pediatricians' discussions with parents about HPV vaccine. So we actually heard what these pediatricians were saying, and it's very disturbing because a lot of them are recommending delay of vaccination. Oh, your 11-year-old doesn't need it, and they'll turn to the 11-year-old and say to the little boy, "You're not interested in girls yet, are you?" So that is not a strong, clear recommendation, and that is not the kind of communication we'd like to see. So a lot of my research focuses on providers, also on ways to help providers do a better job in making that recommendation. And also with parents, because obviously it's not just providers. There are parents who are hesitant or have questions about HPV vaccine. So we've been looking at kind of different kinds of messaging and informational strategies to help overcome parental hesitation about HPV vaccination.
What percent are being vaccinated now?
In Indiana, the data just came out, and I was just looking at it. It's about, do you recall?
I thought it was 36%
Yeah.
combined boys and girls.
And it's gone up. That's the 2016 data. So it's gone up maybe in terms of first dose acceptance. You're writing it down, but don't quote me on this. But I think the first dose is probably in the 40s now.
Yeah, it's heavily slanted.
In Indiana, boys lag well behind girls. Nationally, they're almost the same now. In fact, the CDC no longer separates girls from boys in their reporting of their results. But in Indiana, in 2016, we were tied for last for boys with Wyoming. And so we have a long way to go. But I think to build on some of the discussion about the legislation, I feel like this is a critical moment for Indiana, and there's been a convergence of efforts. It's very exciting. So the American Academy of Pediatrics has a number of efforts going on in Indiana. The American Cancer Society, there's the legislation. There's just a lot, I feel, an energy, and the State Department of Health has been unleashed, and our Commissioner of Health, Dr. Box, is amazing and a great advocate for HPV vaccination. And an OBGYN, yeah. So I feel very optimistic about where Indiana's going. We've improved over, from 2016 to 2017, and I think there's going to be greater improvement. Rhode Island is Rhode Island and District of Columbia are the stars right now. They have initiation rates close to 90%. And, I'm sorry?
It's to 2 now.
As long as the first dose is given before age 15, it's then 2 doses 6 to 12 months apart. If the first dose is given at age 15 or older, then it's 3 doses over a 6-month period. And it can be administered up through age 26. There's consideration now, the FDA is considering increasing the upper age limit apparently to 45. So there's some changes that might, that's not been decided, but there's some changes that may be coming.
So how do you respond when people talk to you or contact you and they're part of the anti-vaccination movement? How would you message your message to them?
So do you want me to start, or do you want to start, Tamika?
I know I get a lot of messages, and especially on social media. And I literally start off with my own story. You know, I was diagnosed at 25 years old. And it's funny, you know, I was one of those kids who grew up and I was like, by this age, I'm going to do this. By this age, I was going to do that, and da-da-da-da-da. And I was focused on my career, and I knew when I wanted to start a family. And cervical cancer was not a plan. It was not a part of what I had considered for myself. So at 25, you know, I go from this life of being a television producer in Washington, D.C., and chasing politicians and entertainers and different things like that, to being a scared girl. At 25, you think you're a woman until something impacts your life. And I lost the thing that I thought at the time made me a woman, my womb, due to this thing that I didn't know anything about. When I was diagnosed in 2001, this was before social media, there wasn't Google, you know, we barely had AOL dial-up. And this thing comes in and there's no instant support, no instant communication. And I go to an encyclopedia or a library and what I see scares me. What are these 3 letters? And so for me, I didn't want to talk about my story. I started talking about my story. Fast forward, now we have, you know, the internet. And the internet is a great thing because it makes everyone a publisher. It's also a terrible thing because it makes everyone a publisher. And so with the anti-vax community, you know, there's a part of me that feels like, well, they just love their children and they want to protect them. But when it comes to cervical cancer, it's personal to me, and I'm not a doctor, I'm not a researcher, I'm just a girl who almost lost her life to it. But what I do know is that if this was a breast cancer vaccine, or as my father died of colon cancer, my mother of multiple myeloma, I have stomach cancer, and I could go on with prostate cancer and every other type of cancer in my family. If we have an opportunity to prevent a cancer, why wouldn't we do it? And I'll tell you, most of the time, the conversation doesn't go over well with the other side because we just won't agree. And what I continue to do is that I know that my legacy in life will not be the lives that I bring into this world, unfortunately, because I can't have children because of this cancer. This is a very real cancer. But my legacy will be the lives that I save. And so I share that in hopes that any mother, any father, grandparent, or person who is on the fence, I ask them, where are you getting your information from? You know, is it sourced information from a credible site? Is it something that someone made up that's clickbait? And a lot of times it is, but people want to believe what they believe. We've been able to talk to people and change minds and hearts and show them where to get credible information, but I don't get combative with anti-vaxxers. A lot of times, you know, you kind of want to because you're like, this is what happened to me. There's a woman here in Indiana. I went to see her in the hospital earlier today. She's a young mom. She is a wife, and she's going to lose her life to cancer. September 12th, there's another woman who lost her life, mother of 2 young boys. There's a woman from South Bend, Lisa, who lost her life. There's a woman, Heather, who had stage 3B, diagnosed 3 months after her second child was born. And I could go on with how real this is. But to someone who is fixated on scare tactics and these clickbait social media site articles, sometimes you just can't change their minds.
Yeah, and I would say, you know, if you think about sort of vaccine attitudes as a spectrum, and extreme one side, I wouldn't even call it extreme, but one side would be, you know, parents or people who don't have a lot of curiosity about vaccines, they just believe they're good and they do it. And then at the other extreme is, you know, really very hardcore anti-vaccine people. That extreme is, they're fairly immunized, if you will, against counter arguments. Mm-hmm. My concern about people who are extreme in anti-vax sentiment is that that belief is not based on accurate evaluation of data and information. It's based on false information, but it can infect, if we're using a immunology metaphor, it can infect people who are not at that end of the spectrum, but are sort of have questions or are hesitant. And it is concerning, as you say, the internet is both wonderful and terrible, and there's a lot of information that's available, and just because it's available doesn't make it good. So I think we do have a responsibility, and I think Tamika spoke to this, to present the factual information and emotional information that's based in fact. And I think that's one of the things that's important about Tamika's story and the story of these other women and men who are dying of head and neck cancers. These are important stories, and they're stories that are based in fact. These are people who are dying from an infection that causes their cancer, from HPV. And that's a fact, and it's a fact that HPV vaccine prevents infection and prevents these cancers, and we know that. So I think it's really important that we get that information out there, that we don't allow anti-vaccine false information to remain unchallenged. But we're fooling ourselves if we think we're going to convince
Exactly.
those folks. Yeah.
But it doesn't mean we stop doing what we do. And, we're focusing on cancer, but the other side of it that, we don't talk about necessarily all the time, or people don't know, are I don't have the exact number, but again, I think it's in the millions again of women who have HPV-related disease going through infertility issues and other issues because of LEEP procedures, cryo-freezing, cone biopsies, and et cetera, because of HPV.
Right.
And that's also problematic.
Yeah, and I think we should think about, so people talk about what are the side effects of vaccination? What are what bad things can happen? I think we need to turn that around a little bit and say, what are the side effects of not vaccinating?
Yes.
Because the side effects of not vaccinating are dire and profound, and much, much worse than the side effects associated with vaccinating.
Yeah, and I just wanted to touch on that. I know I come in contact with the anti-vaccination group a lot because they do attend the public health committee hearings. Anytime that we're going to hear any type of legislation that even mentions vaccinations, then they will show up. And they show up in numbers. They're in all parts of the State House. They're at the front door. I would say making sure they get the legislators' attention. I don't want to say harassing the legislators. Some legislators think it's harassment and have complained on them because they're very aggressive. So they're right there as soon as we come into the State House, all the way until we're up in the chamber and have the committee meeting. Some legislators have talked to them during the hearing, saying that they need to be more professional or don't call out some of these companies or organizations because they can just get very sidestep and bring some of these controversial things that you would say on the internet in these posts, and you shouldn't be bringing those into the hearing. So they just get very passionate. And so I wouldn't say everyone is like that, but some of them are like that because there's usually several individuals that want to testify that's within the group. But the way that I handle it and the way I handle any group is I'm going to listen to everyone. I'm going to listen to, as long as you have concrete information, if you are talking specifically about the legislation and there are things that you want to change in the legislation and there are things that are not correct, because I have worked with them before and they have been helpful in tweaking some of the things that need to be tweaked that could have helped them. I think it was in regards to consent and parental consent when it came to vaccinations. But as far as vaccinations, and so somehow I became one of their pro legislators in helping them out. But as far as vaccinations, if it is a public health concern, then I have to lean on the public health concern because I would want someone to get vaccinated, or I want a child to get vaccinated, or if it's a cancer that we think can get prevented, then I would lean towards that, especially when we're talking about public health. So dealing with this group, I would say I am just very careful in making sure I listen to them and making sure, keeping them focused on what exactly that I can help them with when it comes to policy, and not just listening to all the other things that they're talking about that may not be based on data, that may not be true. That's more about what their feelings are and what their beliefs are that they think is tied up into anything about vaccinations.
Well, you're probably more diplomatic than me. That's why I'm on Ways and Means. But, you know, I feel like we have to be Mythbusters. It's just, I tell you, one of the most frustrating things that happened, and I'm trying to remember which bill it was. You might be able to remember which one it was, but it was one of the bills, of course, that didn't make it off the floor. We had a fellow legislator, female, go up there with her iPad, and she was from my caucus, and she read this anti-vaccination article about the HPV vaccination. I about had a heart attack. I mean, I just could not believe that this woman was doing this. And it's just that kind of rhetoric, that kind of non-factual information that was being presented by somebody who in theory represented 67,000 people in the state of Indiana was just depressing. So I remember at that point it was regroup, rethink, we have to approach this differently. And so that's, you know, was part of that process of preparing this next set of legislation. But I realized that, you know, this has to be fact-based. And so I just immediately get defensive when somebody starts telling that that's anti-vaccination, because to me that it's just they're not using their the knowledge that it's available, and that they need to show me scientific data, and they don't have it, bottom line. So I think it's important to stand strong to them. Maybe I should be more diplomatic.
Well, you know, and in speaking of data, that's one of the things, like, you know, again, myself just as a patient who turned advocate, and there is a lot of data out there about the HPV vaccine, but you know, have to go and look for it, and again, look for a credible source. When we talk about social media, and there have been a lot of studies on social media and the HPV vaccine, there are a lot of clickbait articles, and what we know are, there are a lot of times people aren't even reading the actual article. They're reading the sensationalized headline and then sharing it to their followers, and then the same thing happens and happens and happens, and then there's this mass hysteria over something that people didn't read just based off a headline.
Right.
And, you know, this is where we really do have to be, you know, diligent about what we're sharing. We have to be intentional in knowing that we've read them and where is it coming from, because you click and you go to some of these websites, and just looking at it, you can see once you get on the landing site that this is not a credible site, but a lot of times people aren't even doing that.
And in regards to the data, I was interested in hearing, I don't know, Dr. Simmons, if you have any information on any disparities that exist within our state of Indiana, racially, geographically, anything that you see in your research?
Yeah, so I've recently been looking at vaccine registry data in Indiana broken down by county and looking at different age groups. So one of the there are a couple of key findings that sort of sprung out. One is that counties with a larger rural population have lower vaccination rates. And that is not something that's unique to Indiana. It's actually a national trend. I have a colleague in Utah who found the same thing in Utah. So I think this is a problem nationally. We tend to look at each state and say, oh, Rhode Island's doing great. Wyoming's doing terribly. Mississippi isn't doing so well. Indiana's not doing well. You know, California's doing okay. But within each of these states, there's tremendous disparity. And I think it's important that we not just look at the state as a whole, but look at our communities and our counties. And so that's certainly one of the key disparities, is that rural counties have lower HPV vaccination rates. There are other there's not so much in Indiana racial disparities, and in fact, nationally, Hispanic and African American youth tend to be vaccinated at a higher rate than white youth. So if you want to talk about that as a disparity, it may be a disparity that white teenagers are not getting vaccinated as frequently. There's also a difference when you look nationally at poverty level. People at and below the poverty line are vaccinated at a higher rate than wealthier families. So it doesn't follow all of the usual kinds of health disparities that we are used to seeing. That's why, we have to identify the nature of these disparities and then really come up with some strategies that really focus on, I think, on communities, counties, as well as at the individual level and sort of the big P policy, state policy level. I don't know if you want to.
Sure. So it just so happens I represent a very rural district.
I have a question. When you were talking about the Hispanic community having a higher vaccination rate and the impoverished people having a higher vaccination rate, is that across the board with vaccinations or just the HPV, or do you not have the data to answer that?
So there's data to answer that. I don't know it, but I think it's publicly available. It's the National Immunization Survey teen data. It was just published by the CDC about 2 weeks ago. And that breaks down all adolescent vaccines. So it has HPV, it has meningococcal, Tdap, and it breaks it down by different ethnic groups and poverty level, and also by how rural, sort of rurality. So, sure.
So obviously I have tremendous concern on the distribution within my rural communities. And we know that it was really interesting in a discussion at our HPV stakeholder meeting about the availability of receiving vaccinations through your pharmacy. And with so many dual parents working, not being able to make it because of the physical location of getting to the doctor's office, that would be easy if we could just go do it at the local pharmacy. We're discovering that there may be some roadblocks there and that we need to do a better job of addressing it there. It has to do with billing for your health insurance, if they'll pay for it or not, because it was done through the pharmacy. So what will be quite interesting is that the strategic plan will hopefully point us in the right direction on some of these roadblocks that we can correct. But we do know that the rural areas is an area we really have to target, that is our weak spot.
I was just going to add that the other thing that is probably more typical of rural counties is that they're going to be smaller practices. So whereas in Indianapolis, a lot of the primary care practices have been bought up by the hospital systems, right? And they're large practices. But when you get into rural areas, it might be a very small practice. So keeping vaccine, there are logistical issues that these small practices face in terms of the cost of vaccines and of storing them and maintaining them, that large urban practices don't face. And you would think, I hate to use this term, you would think in this day and age that we would have solutions to those kinds of logistical problems, but we don't yet.
I think I want to throw a question at you.
Oh, I was just looking at the Cancer Society's disparities, and they had listed women who are uninsured. So I wondered, did that show up in also the vaccination? This is for screenings.
Yeah, so in fact, with vaccination, because vaccines for 18 and under are covered by the Vaccine for Children program, so VFC, it's not it's very easy for people to get vaccines who are lower income. And the Affordable Care Act also, as one of its provisions, all vaccines are supposed to be covered for everyone, for all children, 18 and younger. But you're right, I think when you start looking at sort of stage of diagnosis of cancer is one of the things, and one of the reasons why African American women they're more likely to be diagnosed in Indiana at a later stage of cancer, and I think there's access issues around that may be related to poverty and racism perhaps too. Yeah.
And that's exactly what my next question that I was going to ask Tamika is, through your work, we know what treatment barriers exist for women who are actually diagnosed with cervical cancer, since you talked to a lot of cervical cancer survivors and heard their stories, because HA 1278 not only addresses prevention, but also mortality.
You know, I share my story so much because I know as a woman of color, we don't have a lot of women of color who share their stories, but unfortunately, a lot of them don't survive because they're diagnosed at such late stages. And so while I'm sitting here and I may, look like I don't have any issues, I have a list of health issues. I got a Ziploc bag full of medication. I can't tell you how much magnesium, calcium, vitamin D, over the counter and prescription. And, my bones, I try not to fall at all because they're so brittle because of the radiation. And I'm very thankful for, the treatment that I was given. But one of the things, and I'll use myself as an example, and this was before the Affordable Health Care Act, which I'm very thankful for, especially for young adults who were getting off of their parents. But one of the things that is hard once you reach a cap, when you're going through treatment, you think, okay, you have this insurance and you're covered. And this is where I was naive, and I didn't realize that there's this thing such as a cap. And once you reach the cap, then that's it. You got to pay out of pocket, right? And so I remember, having to decide between gas, parking, and an anti-nausea drug that was out of pocket anyway, that was 4 pills and it was over $100. And so there are all these types of barriers when it comes to also blood clots and circulation. When you have a woman who is having parts of her uterus or entire uterus, and you need a flexi toucher, I can't, to help with your lymphatic system. There are a lot of women, when they have lymph nodes removed, I know because, again, I had never known a cervical cancer person before I got my cervical cancer, and I only thought breast cancer patients were the only ones that had to deal with lymph issues, not realizing that anyone who has any type of lymph node removed, they have lymphatic systems. There's a woman here in Indiana, she has to wear compression undergarments from head to toe, 365 in the summer, in order just to compress her body so it doesn't build fluid. And she gets constant infections. She's always going to the hospital, and she reaches a cap. And so that's another barrier. There are people who, if they have a family and they have to provide and they may have a child with an illness, that's another issue. When we talk about just getting women to go and get screened, while we're talking about vaccine, but, September is Gynecologic Cancer Awareness Month, so I've got to step on my soapbox for a little bit. I have never met anyone who wakes up in the morning and they're like, oh my goodness, it's Pap Day. I've been looking forward to this day. Oh my God. Pap Day is the best day ever. And so I think, we have these buddy checks where we're encouraging women to check on their friend and their sister or their mom to make sure that they go get their mammograms. I think we have to also do that for, cervical cancer screenings. And, unfortunately, cervical cancer screening is not easy because there are all these subcategories. It's not a one-stop shop fit all. But this is where we also have to make sure that we encourage people to do it. You talked about barriers earlier. I know that a lot of women contact us because, they can't find a doctor, or they're scared to go back because they're thinking that if it's just pre-cervical cancer or it's an early stage 0 or 1, that maybe it'll go away. And I can't tell you how many times that happens. So there's a lot of education that has to be done too. There's also a lot of community support that need to happen. I think sometimes when you're dealing with a cancer where sometimes you can't outwardly tell if someone has cancer, there's that emotional side of it that we don't think people are dealing with because, they don't have the bald head or, an outwardly missing limb that someone would recognize. And so those are the things that, women really do struggle with. But yeah, there's all type of access that happens. I know people who have had PPOs and they're covered, but they don't realize, my cancer reoccurs and now I have to go back in less than 2 months than my last treatment, but my insurance only covers for this much. And then what happens?
Insurance is a big barrier, but I just want to touch on the screening and the PAPs, because even professional women, I had a colleague who was African American, and she hadn't had a PAP in 3 years. I was floored. I was just like, I'm not even comprehending. I was like, you haven't had a PAP in 3 years? She was like, oh, well, I just don't go. I'm like, you're supposed to go every year. I just couldn't believe it.
Not anymore, actually.
Yeah, so there are new guidelines, and that's why I said the subcategories are so hard. So you don't have to get a PAP every year anymore, but what you do have to do, you have to go in for a pelvic exam, and a pelvic exam isn't necessarily getting a PAP. And so women
Well, she hadn't had none.
Well, right, and so, but that's
doing neither.
that's who I was. I was one of those people who, I was a freelance journalist, loved my job, and I remember I was in my 20s. I'm like, well, I'm gonna get sick. What do I need? Insurance. Sure, I'm gonna take this job, and I didn't get screened, and this was back when you were supposed to go in and get screened every year, and I had missed it, and I was off of my parents' insurance. I had graduated from college, and circling back, so I had someone who, when the guidelines changed, not this most recent time of 2 weeks ago, but
2012.
Yes,
yeah.
thank you. They were shocked that.
Before then.
Okay.
You should have been going.
No,
And
yes.
She was old enough.
Okay.
Yes,
What's the age cutoff then?
65.
I mean, that you shouldn't go
Okay,
every
so-
year.
So
Well,
it is 65, but
yeah.
if you're African American, I have my own.
Yeah,
I
no,
still
that's fine,
need.
yeah.
If you're African American woman, the cutoff is 65. But if you are African American, you still should go. There is some research that shows that African American women still need to go beyond 65.
No, I mean, isn't there an age where you should go every year? 'Cause
Only
as a-
only if
No.
you have, only if there's an abnormal result.
Right.
Or now, and they keep, so part of the this is this challenge.
This is the challenge.
How do you when there are changes in guidelines, how do you effectively communicate that? How are they adopted by providers? Because that 2012 change in the guidelines, which shifted from every 1 year to I believe every 3 years if the result was normal, a lot of Pap test providers didn't institute the new guidelines, and a lot of women didn't know that the guidelines had changed. And they're confusing. And then now they've just changed them again.
Yeah.
And these are, it's debatable. There's some debate about whether the changes are good or not. But there are new techniques that are being developed, like HPV testing.
So
what I was
my message to women is to go to your provider every single year to get screened. And what that screening to me means, and my message to women, is that you're going to have a conversation with your doctor, which is why the emergency room and wherever else can't be your doctor. And I've been one of those people too before, where, when something happens, don't have insurance, or I don't have a regular doctor, a clinician, so I go to the emergency room. So my message is, one, get a provider, even if it's at a clinic, wherever, get it. And then talk to your doctor and see what is best for you. But that's why you have to have a conversation with, and when I say clinician, provider, I mean nurse practitioner, whomever. And the guidelines are there for a reason, but they're just that, guidelines, which is why you have to talk to your doctor.
No, I'm a little
Agreed.
cautious. I'm still going every year.
No, but I'm saying you should,
I'm
should go
doing the
every year.
PAP. I'm getting the full everything every year.
So, and can I tell you something? I bet your doctor's not doing it every
Well,
single time.
I hope they're sending it off.
I bet they're not, though.
You think they're just keeping it at their
Bec-
office?
No, I think that you're probably getting a pelvic exam and not necessarily a Pap swap. And not to, I'm just we putting all your business out there.
No, I
but
see
this is what
them.
I talk about coochies. This is what I do.
No, I see them doing that. I see them doing that.
So what I'd like to talk about is the co-testing.
I'm gonna take a picture next time.
It wouldn't bother me if people send me pictures of them in the stirrups all the time. I constantly get pictures of women in stirrups. Please do.
So at my age, at 58, you know, I feel like knowledge is power, and I want to know, am I a carrier of an HPV high-risk virus? And so I have been preaching to every one of my friends and family is when you get your Pap smear, get co-tested. And what that means is they'll do an extra test to confirm if you are a carrier of that high-risk virus. And if you are, then you can really be quite diligent to make sure that you are constantly screened and they're looking for any abnormality in your cell changes. I fortunately came back negative, but what I explained to people is it doesn't mean I might still have HPV, I just don't have the high-risk strain. Or I just had it at one time in my life and I fought the virus off. But knowledge is power, and so many people have no idea that you can be co-tested to find that out. So I think it's really important. And I have to tell you, I had to fight with my gynecologist about taking that because she looked at me and she said, "You've been married for 34 years. You don't need to do that." I said, "I want it done."
Let me speak to that a little bit too, because
And that's such a new term, co-testing.
right.
Yeah.
Well, and the new guidelines actually allow, I think, for ages 30 and older to have HPV testing primary as the only testing, but we won't go into that right now. But I think part of the stigma around HPV infection, there's this kind of sense that there has to be some blame to go around, or that it somehow indicates infidelity. And I like to think of it as, there was a concept of no-fault insurance. I don't know if you've heard of that. Where if there's an accident, you don't worry about who's at fault. The insurance company covers it. This is a no-fault infection, and you don't know when someone's been infected. There's no way to know. The infections can come and go as well. Sometimes they may clear entirely, but sometimes we know, some of my colleagues have done research to show that a high-risk HPV infection can be detectable now, 3 months from now, 6 months from now, and then can disappear, apparently, and then reemerge. And so this is an infection that has these qualities where you don't know that it's gone away. It may not be detected even by these sensitive HPV DNA tests. If there's some immune suppression that goes on, there's been some case studies of women who've had renal transplants and they take immunosuppressive drugs so they don't reject the transplant, and then they're diagnosed with a new HPV infection, but they've definitely not been having sex, so they didn't acquire a new infection. What you have is immunosuppression that led to this kind of latent infection reemerging. So we just have to get away from blaming people for this infection, for assuming that it means infidelity. It's an infection that we are best to think about it as a no-fault infection. A colleague of mine talked about in the movie, someone you love, Fred, talked about if you have HPV, what does it mean? It means you're human.
Because it's very common. Almost everyone has it or has had it or is going to get it. And, I always get someone crying and they call me and they're crying, or they send me a message. And my first thing is, you're not unique. You're not a unicorn. And usually, hopefully, that makes them laugh. And, but it's true. It's very common.
And let's talk about how this affects men. I know last year some interesting numbers came out about how this HPV is affecting men, not only women, and cancer diagnosis.
Yeah, so I don't want to hog the microphone, but I'll start by hogging the microphone. So there are now more head and neck cancers that are related to HPV diagnosed every year than cervical cancer. And that's in men and women. There are actually more head and neck cancers diagnosed in men than cervical cancer in women. And that is not in any way to diminish cervical cancer and how it's an issue we need to continue to be concerned about. But as we've learned more about HPV, we've identified additional cancers. And one of them it's called oropharyngeal cancer, or more simply head and neck cancers. About 70% of these kinds of cancers are caused by HPV. And in particular, among white men, it's been increasing at a kind of alarming rate. If you look at the curves of increase from 1999 to 2015, among white men, it's a very steep increase. Among African American men, it's not. Among white women and African American women, there's not been a substantial increase. But it's a white man's disease, and it's the increase is really alarming. So that.
Right. So I have a sister that's a physician, and she keeps telling me over and over, you cannot believe how much more we are seeing this in males. And she's in the state of Michigan, and so I know that it's becoming more and more prevalent. And one of my conversations with my fellow stakeholder at the meeting I brought up was, here we are in a legislature of 80% men, 20% women. I have an idea. We need to really emphasize this new statistic that we're looking at, because this is not just a woman's disease anymore. This is a society's disease, and we need to make this really well known. And so I think this is part of the discussion that we really have to get out there, not again to diminish cervical cancer at all, but it is not a female problem. It is a male and female problem.
Well, I just wanted to touch on, I think what's interesting about the men impact is when we had our hearings, one piece of legislation, right now I said the legislation, we currently give the information out to girls. So one of the bills wanted to provide that information to boys, because of course this impacts boys and girls. We had men come and testify who had HPV, and they gave heart-wrenching testimonies who now had cancer. And the terrible part about it is because I don't know what goes through some of these legislators' mind, but I think when they hear men getting this disease, somehow they still connect that it must have been sexually transmitted. To them, somehow sex still comes in their mind. So when they start hearing the men talk, even though they say it wasn't sexually transmitted, or how they're saying they got it and they're telling their story, and they're in committee, to them, that really connects them to the sex. They still put that stigmatism to it. And providing that information to boys, they just didn't want to take that extra step, because they were still connecting. It brings back that sexual orientation to it. And so like Representative Nagel said, she had to remove all those triggers, and that was a trigger. So when you start saying, okay, we want to now provide information to boys, this is also affecting men, they start making that sexual connection. And to say, okay, now we're just going to focus on this is just cervical cancer, we're looking at women, they're like, okay, it's like a tunnel vision. Okay, we can do that. So I think it's going to take some hard educating for them once we take this step to then now say, okay, this is really hurting men. This is really hindering men, and not for them to connect men with sex.
Yeah, but we were talking earlier about how, one is, I don't really care how a deadly virus is transmitted. If it's killing people, if it's giving people cancer, we shouldn't be even sure, understanding transmission is important, but we shouldn't be passing judgment about it. We should be looking ways to prevent it. The other thing is let's not talk about sex as if it's some kind of aberrant behavior. All of us here are here because two people decided to have sex. That's the fact of it. And those of us who have children and want grandchildren, we should be hoping that they will in fact have sex, because otherwise we have no grandchildren. So I know that, when you're talking legislation, you can't be quite as blunt as that, but it bothers me that we shy away from it. Although I understand why we do, but it's silly. And as I was saying, I don't know how many of you have heard of the Shakers. Do you know who the Shakers were? They didn't believe in sex, and the reason that many of you have never heard of them is because there are no Shakers. They made great furniture, and you can still buy their furniture, I think, but yeah.
So December 31st comes. We have this strategic plan that's due to the General Assembly, to our governor. How can we make sure acts like this live and make a difference when it comes to mortality and morbidity and all of that in our state? How can that move forward?
Well, first, we don't know exactly if legislation is going to result of this. What I do think is that we've already kind of identified some barriers that we're researching to figure out, is there a legislative fix for this? And in particular, it had to do with the pharmacies, if you got vaccinations there. So I'm in the process of analyzing that to see if there is a legislative fix for that. But I think it's more of anything is just continuing talking about it, the education behind it. If you can get 150 senators and House of Representatives behind it, representing the entire state, think about the impact you can have on your voice to all of those people and convincing them how critically important this is for the health of Hoosiers. So again, I think it's just keeping that momentum going. We have our official cervical cancer month, but I think we also have to continue talking about all the other cancers that are associated with this virus. And slowly but surely, those that are struggling on the whole sex conversation, I believe we can get them to break through and get a little bit more comfortable with the idea that, look, I mean, you just can't control every facet in life. And as a whole, as a society, we got to get beyond these barriers that, life isn't perfect. And so we have to deal with it as a society. And you can't live in a bubble. It's just not how it works. So I will continue on that pathway.
I don't know if anyone has questions. I don't know if you were given index cards, but after this next question, I'll open it up to the audience. But Tamika, I wanted you to share, I know you're passionate about sharing your story, of course, and getting others to do the same, which is why you started Survivor. So talk to us of what impact you see that making when you're out, people are sharing their stories in their local communities.
I have to tell you that again, I have no biological children. But a lot of times I look at these women who come into my organization as my babies, even though they can be older than me, the same age. And they come in and they're like, I don't know how to share my story, or I want to share my story. I don't know if my story can make an impact. And then I go on and I see them, doing live news, sharing them at community events, even getting in the political realm of things. And it's a beautiful thing because we know that's how you create change. One of the things when I first got into the advocacy world is that I really didn't see women who were diagnosed with cervical cancer sharing their story because of stigma and shame. And so for me, I felt alone. I really felt like a leper. And I sought out to find other women. And at first I couldn't find any. And then I found women, but they were only willing to talk to me. One of the things that I noticed, when it comes to lung cancer, breast cancer, skin cancer, and various others, you have these people speaking out about it. They're spreading awareness and prevention messages. We need that for cervical cancer, especially because unlike other cancers, there's something that we can do about cervical cancer now, other HPV-related cancers as well. But specifically when you look at cervical cancer, because there's screening tests, the diagnostic test, and then you have a vaccine, this isn't something that we're looking into the future to do. This is something that we can do right now. So for me, I saw researchers, I saw clinicians, I saw those in the legislature doing the job, community nonprofits that they were supposed to do, but the needle still wasn't moving. And then, with my producing hat on, I thought, it's because they don't have those personal impact stories. These women and family members, the caregivers, aren't out here talking about what really happens when someone not only experiences cervical cancer, but when they die from it. Because there's this whole thing that if you're going to get cancer, get an easy cancer like cervical cancer. And it's not easy. No cancer is easy. And so for me, it took a long time. It wasn't something that happened overnight. I mean, you look at someone like, an organization like the Susan G. Komen Foundation, which has advocates around the world sharing their story. You know, we take my organization or the National Cervical Cancer Coalition, the Foundation for Women's Cancer, and you know, out of all of us together, we may have 500 women whose stories are listed throughout our websites. And with, you know, my organization being the largest database of cervical cancer survivors, and of course the American Cancer Society, but these women weren't outwardly sharing their stories. So now when someone calls any of the organizations and we all collectively work together, we have a partnership in saying, you know, we need a survivor in Indiana to come. And we can go and find someone who is willing to share her story. It's a wonderful thing, and you know, it sounds like something really easy, but it wasn't. I remember when, you know, early on, someone introduced me to someone, and they mistakenly introduced me as an ovarian cancer survivor. I didn't correct them, and I didn't correct them because it was easier. It was easier because I didn't have to explain the connection to HPV, and I didn't have to deal with that person looking at me like I had brought this on myself. But it also did something to my soul when I had to kind of hide a part of me, and I said I would never do that again. And so when I was single, it was not sexy talking about cervical cancer and HPV as much as I do. But my mother, who's no longer with me, is very religious from a Bible Belt state. You know, she told me, she said, someone's grandmother came up to her and said, you know, I read your t-shirt, which was a cervical cancer prevention t-shirt. I did what it said on the back of the t-shirt. And my mother, who used to tell me, you talk about private things too much. You're a girl, don't be ashamed of yourself. You're gonna shame the family. Before she died, she told me that she was proud of me. And it made me feel like, you know, I don't know the reason why this happened to me. Because I used to say, why me? What did I do wrong to get this? And now I know there was nothing I did wrong. I know if my mother was alive and the vaccine was alive at the time, she would have gotten the vaccine from me because she would have wanted to do, and my father, anything to keep me healthy and protect me. But what I will do is promise that I will make my survivorship count. And I do that by empowering women to share their story of cervical cancer, because at the end of the day, no other cancer has what cervical cancer has. And I want those women to feel empowered that because we have those things for our cancer, that we can do something about it now. We're not looking for the cure for cancer. We are, but we found the first line of it with cervical cancer. So that's really how I kind of like empower them to make their survivorship count, because a lot of times they don't feel empowered that they can actually do that.
Are there any questions?
Yeah, I'd like to have you address the state legislature and the mandates with education, public education. What role do you think public education could play in health curriculum within the public school system itself to attack some of the issues that you're addressing today?
Could you also repeat the question for those who are sitting way in the back? I think people are having a hard time hearing.
Sure.
They surely heard me.
So the question was in regards to how public education can play into the part of the education of vaccinations, sexual health, I guess, all of that.
Yeah, the required health curriculum.
Right, the required health curricula. So again, this hits that area of a very touchy subject within the legislature, and it is quite frustrating. There are several legislators, including myself, that have been very supportive on trying to pass legislation and improving in this area. We keep hitting roadblocks, very frustrating roadblocks, because there is a very strong group within the legislature that believes, well, I guess I can't help but say it. Here's my politically incorrect statement: ignorance is bliss. It just doesn't make sense to me personally. I think the problem is that they feel that all this information should be taught at home and not by a third party, so to speak. And so there is very, very tight restraints on schools and what can and cannot be taught in a health class. I don't agree to it. I will continue, along with other legislatures, pushing hard, trying to change that mindset. But that is what we are up against, is a group that feels very strongly and tends to be very, I would describe as more religious right motivated, that any conversation that relates to sexual activity should not be discussed in a school setting. It should only be discussed at home.
And on the internet.
Right, like.
Just saying, any parent who thinks that.
Yeah, and I just want to say, right now, we do have in place, so the information that the girls are getting in school, they get the information, and then when kids are in the 6th grade, they do have to let the schools know if the parents want them to get vaccinated or not, and then they give that information to the State Department of Health. But like Representative Nagel said, it's very confined on what the schools and what the schools can't do and how much information can be shared and what can be shared and then what goes to the State Department of Health. So that, and we've had legislators try to tweak that or change that to try to push the envelope a little bit more, saying, okay, can we share information now with the boys, or can we provide more awareness to the parents? So that's what some of these bills have been along the way, and that's what keeps getting shut down.
And I just want to correct something that I said earlier. We are looking for a cure for cancer, but with cervical cancer, we don't have to. That's what I meant by that statement. I got my words wrapped around, so I want to make sure that I clear that up for you all.
And there were a bunch of organizations that issued a letter, including our own IU Simon Cancer Center and all the NCI designated cancer centers in the country, advocating or proposing the elimination of cervical cancer, which is achievable in the United States with high levels of vaccination and screening. We can eliminate it in the United States, but it requires that kind of the legislative will and the personal and public health will to make some changes.
Which is so important because, again, this month is Gynecologic Cancer Awareness Month. For example, for ovarian cancers and many other GYN cancers, they don't even have a diagnostic test to detect those cancers. And so here we have a cancer where we have the diagnostic tools, and we also have a vaccine to prevent it. That's progress. But we have to push forward to make sure that we can get to this achievable, part of eliminating it. We can achieve that goal.
You mentioned that cervical cancer and head and neck cancer were caused by the HPV virus. Are there others? And if so, would you list them, some of them, please?
Sure. So there's obviously cervical, vaginal, vulvar, penile, anal, and head and neck that we know of. There's also research, there's always a research going on. There is some suspicion that some non-melanoma skin cancers may be related to HPV. This is all not ready for prime time in a sense, but HPV is it's everywhere, and so, and it infects the skin. So, I think there's a lot of explorations of all different kinds of cancers that might have some connection to HPV. But the main ones that we know of for sure are the ones I listed.
And are those types of cancers solely caused by HPV?
So,
or are there other things that
right. So with cervical cancer, the belief is that 100% of them are caused by HPV. There's a small fraction where they haven't identified for sure that there's so many different types of HPV, but the vast majority of cervical cancers are caused by, the 7 types that are in the vaccine or that are prevented by the vaccine. But people basically believe that 100% of cervical cancers, something like 90% of anal cancers, about 70% of head and neck cancers, a smaller proportion of penile cancers, which are awful but are exceedingly rare, and vaginal and vulvar cancers. I don't remember the percentage exactly, but it's not a small percent. It's like maybe 40 to 60%, although I could be wrong, but somewhere in that range, I believe.
Last questions? Well, I put my head back for a second, and I just noticed if you want to read Henrietta's story and hear about the cervical cancer.
If you haven't read it, it's amazing.
Library card. Well, thank you all for joining us. Feel free to give us your thoughts and comments on your way out, and have a great evening.
And I can say something.